So this guy has actually been pretty sick. He has chronic pancreatitis. You can see he's got a pancreatic stent in place. And he actually had occluded his SMA. So there is a stent extending from his iliac artery. This is a stent. And that stent is feeding his SMA. This is the stent here. But what happened was also he had really bad gastritis and an ulcer, which is part of his problem. He has chronic pancreatitis, a really, really bad ulcer. And then on this exam, I know the contrast isn't very great, but basically he had developed a pseudoaneurysm of one of the branches of his splenic artery. So unfortunately, he also has thrombosed off the origin of his celiac axis, and he's thrombosed off his SMA, and it's now being fed by this stent from his iliac artery. So when we found the pseudoaneurysm, we showed it to the IR colleagues, and they said, well, normally we would go in, go through the celiac axis and try to block off the pseudoaneurysm, like stent across the splenic artery, or coil proximal and distal to this. But because the celiac axis is thrombosed off, we can't get there. And we don't think we can. They've even thought about going all the way up the SMA stent, through the pancreatico-duodenal arcade, across the hepatic artery and splenic artery, but didn't think that their catheters would be long enough. So then they decided they would try to percutaneously get to this lesion and then inject it with thrombin. Before they could do that, the patient developed a catastrophic bleed, and he went to the OR, and they clipped this off. He was basically bleeding. The pseudoaneurysm had started bleeding. And then actually now on our follow-up exam, I don't have it here, but this stent has rethrombosed off from low flow. So he's got a lot of issues. But this is a splenic artery pseudoaneurysm in the context of a patient who had both chronic pancreatitis and a gastric ulcer. Mm-hmm. So a couple of teaching points about that. So pseudoaneurysm, visceral artery pseudoaneurysms. 60% are from the splenic artery. They can also be from the hepatic artery or GDA. So if you, the most common cause is pancreatitis. So any patient with pancreatitis, look for a pseudoaneurysm. They can cause catastrophic bleeds, usually abdominal pain, but you can present with melena. But we basically, a lot of times they're silent until they bleed, so we have to catch them. The risk of pseudoaneurysm rupture is about 76%, which is much, much higher than for a true visceral artery aneurysm, which is only about 3%. It has a really high mortality. And then the treatment can be surgical, IR, so you can either stent across it if it's a critical vessel that you need to maintain patency, or if it's a vessel you don't necessarily need, they usually coil proximal and distal to it so that even other vessels that are feeding it will also be taken out. Or you can do direct thrombin injection. That's usually for femoral artery pseudoaneurysms, but you can also do it theoretically for a visceral artery one.